We're going to hear from both Cynthia Gagnon, an occupational therapist that we've worked with for years, who's in Quebec, and Emily Wolinsky, who has shared her thoughts with us in the past. So dealing here with sexual and urological issues in the SMA and Duchenne population, but I'm not sure which one is going to go first, so take it away, whomever.
My name is Emily Wolinsky. I am 46 years old and live in Austin, Texas. I'm the Director of Outreach and Education for the Christopher and Dana Reeve Foundation. I was diagnosed with spinal muscular atrophy at I was 18 months. And I was born in upstate New York in a very rural community with two parents that my father was a special education teacher, and my mom, who eventually became an administrator of an elementary school. And then my mother is, my mom stayed home, and then she also did some part-time work, but she is deaf. And so my parents both had kind of unique experiences with disability that I think really allowed me to fish and look at my life a little differently than a lot of children and teenagers and adults with spinal muscular atrophy at the time. I was raised to be very vocal and independent and I knew my rights, even though at the time it was in the 70s and 80s, and so it was still pretty early for education access and public access and employment access. But over the years, I really developed my skill set. And so as an adult, I've done a lot of work mentoring adults. I started a nonprofit called NMD United, Neuromuscular Disabilities United, for adults that are living with neuromuscular disabilities. I found that we were incredibly undersupported as a population for a very long time, and a lot of people just really needed peer mentorship, support, and a way to get their questions answered. And so we had formed in around 2014 as a nonprofit, but before then, we've been actively part of a Facebook support group that is invite only, adult only group, and I became kind of a leader in that community. And one of the things that I learned a lot about was catheterization, which is something that in all of my years I had never heard about. I didn't realize that there was a way for me to use the bathroom that didn't involve someone picking me up, getting my clothes off, putting me, on the toilet, interrupting. I had to interrupt my day for hours sometimes to use the bathroom. And this became, as I got older, very, very challenging. It impacted, in high school and college, it impacted the parties I went to, how much I drank at those parties. It impacted, my dating life. It impacted my work life. I was a high school teacher for 7 years. And, teachers are famous for holding their bladders, and I was definitely used to it. But I couldn't use the bathroom at school. And, as I got older, especially living in Texas, where it's very hot, I was very dehydrated. I was developing a lot of more infections and respiratory issues because I couldn't hydrate as well and clear secretions. And so in 2016, I started, I would say 2014-ish, I started learning more about suprapubic catheters. and what they could do for me. And the first thing I experienced when I started learning about them was just kind of this awe from the community members that I knew that had them, that talked about how easy it was. And it was really, the answer I'd been looking for so many years. And not once in all of the years of my life had a doctor, a neurologist, anyone experienced with a person living with spinal muscular atrophy, not once had a doctor ever spoken to me about how my personal care needs were impacting my independence. And I was a little spicy. I was a little frustrated. I was like, I just had no idea why, doctors had never mentioned this to me, never said, have you ever thought about getting an SPC? Oh, and or even brought up the idea. And I feel like it was kind of assumed that like we just magically got out of our chairs and like people just magically lifted us, or we got this equipment to lift us, or, but I didn't realize that this was a very popular thing that like people, that people could get fairly easily. It's a day surgery, takes an hour, come home that day, and suddenly you're peeing out of a tube instead of having to get on the toilet. So it really made a huge difference in my independence. And so I started researching it, learning about it, learning what it meant. And then in 2016, I was a little scared because I hadn't had surgery and I was a little worried about my respiratory function. So I started, talking to more doctors and just seeing like, can I go under, sedation? Is this possible? I learned from people that I could do kind of very light sedation to do at SPC. So a lot of the questions that I was asking were easily answered. These were not challenging things to figure out, but at the same time, I just didn't even know to ask those questions. And so I started interviewing different urologists, and it was interesting. I would go into my urologist meeting, I would sit down. The first question they would say, is, why are you here? I would say, well, I would like to be, more independent, and I would like an SPC. And a lot of times it was kind of like, well, there's really nothing wrong with your bladder. And it's, and so it was, they didn't really know what to do, you just need this for what? Independence? What do you mean independence? And I would explain, well, I'd like to go and have a glass of wine every now and then and not have to rush home after dinner to use my ceiling lift to get on the toilet, or I need I'd have to go through these long explanations. And then I found a doctor, Dr. Grady Bruce in Austin, who is an amazing urologist. And he sat down with me and completely felt what I was going through, and was very, thoughtful and heard my story and said, yeah, you should be able to go out and have a beer and, and stay out for the evening and watch a movie or go to dinner and come home. And, you shouldn't have to take off of work to drive home in the middle of the day to use the bathroom because there's no accessible bathrooms on the campus that you can easily get on the toilet with. And he's like, absolutely. Like, there's no reason not to do this. And so I went in 2016 in July, I believe it was July 8th. And I had my catheter put in, and it's been a very exciting experience ever since. It's changed my life, and I've made it kind of a mission of mine to tell people my story and educate people about what that experience is like. I've mentored probably over 50 individuals with spinal muscular atrophy through their experience with catheterization. They call me right after their surgery. I know I've studied, I've learned, I read about bacteria now. I know I look up things like I was actually just reading some test results because I have a bit of an infection at the moment. So I was, studying all the bacteria and learning all the, I have an antibiotic protocol, and I studied, different types of ways to disguise my catheter. So it's not out in the open. It's not in the way. I've been able to counsel people with spouses, and through their questions regarding intimacy, regarding is this going to impact my sex life? Is it's weird? Like, how do I get it out of the way? Am I going to pee all over my partner during sex? Like, what's happening? And so I've done a lot of mentoring and talking to people about this, but ultimately, I think it's really important, and I go to a lot of peer SMA summits and explain and give speeches on my experience, and I think it's really important for families and for physicians to see how important it is that biomedical assistive technology. That's kind of how I frame it. It matters. It really makes a difference in our lives. I don't think it's for everyone. I do think that people need to be informed of all the different options, but for something that could easily be removed and reversed, I really think that for a lot of us, it's worth at least trying. And I do think it makes a huge difference. It impacts our home healthcare hours that we get. It impacts like I said, our ability to hold down employment. It impacts our dating life, our friendships, social life. So I've just been a very big advocate, and I've done a lot of work and mentorship, and so it's just kind of a side thing. I never thought that I would be asked to go around the country and talk about how I pee. Never in my life as a child did I imagine I would be speaking to a room of doctors at Stanford today about how I go to the bathroom. But I am privileged to do that. And so that's kind of my shtick. Living with an SPC has pros and cons and trade-offs. It's not all wonderful. You obviously have a stoma, and there's bacteria, and I am prone to a lot of bacteria and infections. So I can develop antibiotic resistance, and there's always risks. But I think that I've had to really balance the risks versus the reward and my quality of life. And I found that this trade-off has been incredibly important for me. So I guess that's basically my shtick. And I just wanted to, I guess I'm here to tell, I just was here to tell you my story too.
But thanks so much, Emily. That was great, both in terms of just an indication, as somebody said in the chat, of self-advocacy, irrespective of what the goals are, but also in terms of the specifics in terms of dealing with urination. There have been a couple of questions that have come up. I don't know if anyone has any questions in the room, but I think there is one. So Connie Wolford has a question.
Emily, thank you so much for sharing that personal story. And I'm sorry if you answered this already, but 2 questions for you. Your incidence of UTIs, can you speak to how that changed after you went for the suprapubic catheter? And then any issues in getting insurance authorization for the procedure given that it was not a medical necessity per se?
I'm really glad you asked those questions. So I first UTIs. I hadn't had too many UTIs prior to the surgery. I had a couple early when I was sexually active, like most women. Your UTIs kind of come about, but you learn what to do. I would go to the bathroom after sex, and it would kind of clear things out, and I prevented an infection, and I got lucky that way. But after the surgery, I do experience more UTIs. I get 1 to 2 a year. My doctor and I have we have a good relationship and a protocol situation set up where if my bacteria levels get to be over, I believe 100,000, I forgot what but whatever the case is, if they get elevated to a certain number, that is when we treat. Also, he always said, look, if you have a fever, that's like the key. Like the fever was really the point where he would say, okay, you have a fever, let's get you on something. Since then, I have developed, I've developed a common allergy that a lot of people I know with SMA have to Levaquin, which I don't think has anything to do with the SPC. I think that actually I developed that allergy before the SPC. And then I have an allergy now to Bactrim and to macrobid. So I'm a little bit, I get nervous when I have to be treated. Right now, I'm actually on a really strong dose of amoxicillin that's been rough. I really don't like to be treated with antibiotics if I can avoid it. So I have a lot of protocols, how I clean the equipment I use, like the bags that I use, how I change my catheter. I go over with my caregivers exactly, how to sterilize and make sure that I stay as safe as possible. And my body has, I think, kind of acclimated itself to the catheter. And so over the years, it really hasn't been that terrible. It's been a really long time since I've had a UTI. And of course, I don't really know what I have right now, but I have something going on with my kidney. It might be a kidney stone. I do know that I'm really thankful, though, that when I do have infection of any sort, I can hydrate. And so the hydration really helps as well. As far as insurance authorization, my doctor called it a neurogenic bladder. And I don't know if that's a lie. It probably was. But my doctor, really was on my side and really believed in what I needed and what he was going to do. He didn't make me go through all of these extraneous tests. Sometimes insurance requires that if you have a neurogenic bladder, you have to get I forgot the name of it, but basically a really horrible test where they fill your bladder up and then put all this pressure on you. And a lot of my friends have to do that. My doctor did not make me do that. He said, look, we're just going to go and get it done. And it was wonderful. I mean, he's just been absolutely amazing for me and really safe. There's a Hoyer lift in his office. There's accessible equipment, which is so rare. The catheter he installed, he put in one that was kind of, sometimes they gauge you up and they put in a certain kind of starter catheter. And then once it develops kind of like a track, then they put in the Foley. But for him, he just said, we're going to go straight to Foley. We're going to make it a 20 gauge, which was pretty large. And he made choices that actually have benefited me a lot because I haven't had to struggle with going back and forth to the doctor all the time and disappointment and that appointment. And I feel like sometimes, especially with some of the friends and people that I've mentored that have gone through this process, that, it really depends on the doctor, and some doctors make it incredibly easy and some really complicate things. And, but I don't know if they're doing this because of insurance or not. I imagine it's because of insurance, but I also just imagine it's also just kind of a disconnect between like our lives and the amount of logistics it takes to get certain things accomplished in our lives, and a lack of like real empathy in that situation, like a lack of real empathy there. And so, yes, so that's my answer to that.
That was a great answer.
Thank you for your comment about hydration and dehydration. But my question is, can you comment on non-invasive catheterization like the Pyrrhic for women or condom catheters for males?
Like it's a nightmare. Like people like it's one of those things. The Pyrrhic is, you have to be in a very specific a specific position. It's usually in bed, because people with Pyrrhics tend to be people living in nursing homes that are in bed, and there is usually a lot of leakage and drips, and the Pyrrhics themselves are incredibly expensive. Like, I think it's like one Pyrrhic is like $10 or something like that. They overcharge like crazy, and insurance doesn't cover the Pyrrhic. So, so people are buying these really expensive machines. Then they have to go and buy the individual Pyrrhics. Then they get the Pyrrhic and they're all excited. They go to pee and they have to pee. Like, if you've ever had to stop yourself from peeing in midstream and like slowly release pee, it is incredibly difficult. And most people just spill, and then it ends up all over their clothes, and then they end up having to change, and it takes a bunch of time. Condom catheter, I don't have a penis, but from what I know, from my friends that are men that have used them, I've had long conversations with them. It's sometimes a little embarrassing for them, but I've learned that it can be very awkward, because a lot of times they need to be erect in order to get the condom on, and it's sticky and it hurts and it pulls at their hair, and it's just like a lot of them are not into it. A few of them can manage, and they get it on with, whether it's with their spouse helping, and maybe they have a little assistance with like lubrication or whatever. But it's definitely a challenge, I would say, for both of those options. I don't feel like those are options that are really, really smart for independence and cost. It's expensive.
Great answer, thanks. I mean, just to follow up to the last one, in all of your talks around the country, have you met with many men that have gotten suprapubic catheters? It seems like it's more common in women, but I'm not sure.
More and more are doing it, especially because they've been hearing from all of us ladies, and then they're like, wait, is it a lady thing? And we're like, no, the stoma is right below your belly button. Anyone can get one. And then they're like, really? And then so now I've actually been mentoring a lot more men. And that's been exciting, because I just, like I said, I see them through the process, and they seem much happier. I think it's a lot. I didn't realize how hard it was for men to pee. I was always jealous. I always thought that it would just be really easy, but a lot of them explain, they have to be in a certain position, and sometimes it's just the angle and the urinal and this and that. And I didn't realize it requires almost as much effort for them to go to the bathroom as it did for me to go to the bathroom. And so, that's how that goes.
Excellent. Thanks, Emily. This has all been really great. And I think it sets up Cynthia well. So let's switch over to hear what Cynthia has to say. So thank you.
Thank you, and I think it links very, very well. So I'm just going to get to my presentation. So I'm an occupational therapist by background, and this is really the work of so many people in my teams: occupational therapists, nurses, physical therapists. And we did a lot of consultation to get to this talk about exploring solution to enable sexuality for people living with neuromuscular disease. And yesterday we had a very great discussion, Emily and I, on certain of the challenges. So why is sexuality and why should we discuss it with our patients? So sexuality is really about many things, which is biological sex, gender identity and role, sexual orientation, pleasure, intimacy, love life, and reproduction. And it can manifest as several things like thought, fantasy, attitude, role, and relationship. Next. There's a lot of factors influencing sexuality. And here, the main point of this talk is that it is an interdisciplinary topic. Not any one of us can address sexuality alone, and we need to think into consideration many other factors. Next. There's, of course, the physical act. Next. Sorry, it's going to be a lot. So making love, caress, masturbation, kissing, hugging, touching. Next. And there's a lot of myth on sexuality. And there's a lot of, and still and I think that Emily spoke a lot through this. So why do you need a catheter for independence? What is that? I think it's even worse on sexuality, because a lot of people will think that people with an handicap situation can have sex, or people with disability can be desired. Next. But sexuality is a biological need and a right for every human being. And it's been and still the object of discrimination for people with disability. Next. Should we address sexuality in healthcare? Because oftentimes what is said is that, oh no, it will feel uncomfortable to my patient or to his family. Because of course you have adult patients, but you have also adolescents that also have sexual needs, but then you also need to take it into consideration with their parents. So sexuality contributes to overall health and well-being and is an indicator of quality of life. It is important to being able to express his or her sexuality, as it is an important dimension in building a satisfying life. And what is very interesting is that although 72% of patients with chronic illness have problems with their sexuality, only 18% will be able to address them independently and not, to make their own solutions. So they need help because it's a complex subject and it can be related to so many things. Next. So all of what I'm going to be showing you today and what we're going to be discussing is really about a standardized process that we did in developing clinical care practice guidelines for neuromuscular disease. And we did it in a very standardized fashion. Next. So we have two products that we've done. Both of them, sorry, my slides are in French, but they are both available in English, and I can provide you with the link. So there is one for the role in physiotherapy, and is one for the role of occupational therapy, and there's one for nurses that is coming up. And I've also put forward one that has just been out, which is done from Holland Bloodview, which is a kids facility in Canada with Muscular Dystrophy Canada. And it's really interesting because it touches upon teenagers, which we do not in our two adult guideline. Next. So first is how can impairment in neuromuscular disease influence sexuality. Next. So there's several impairment, and I will go very fast over them. Next. But just to give you, so of course there is decreased muscle strength in neuromuscular disorders. So that can lead to difficulty or inability to assume certain position, decreased endurance, decreased ability to close hand, or myotonia will provide difficulty with masturbation. Body change also will affect self-esteem. There's also several diagnoses that will bring upon pain, either as primary or secondary. And will be difficult or inability to assume certain position or fear of having pain during the process. Next. Central nervous system will also affect your ability to have a meaningful and fruitful sexuality, increasing fatigue, where it could decrease interest, but not necessarily decrease importance, endurance. In myotonic dystrophy, we have hypersomnolence, which bring up less opportunity. There's a lot of those neuromuscular disease that can bring upon apathy or general cognitive functioning on the other end, where you will have adolescents or adults that will have a risky behavior in terms of sexuality. Next. The digestive system have a very profound impact as well on sexuality. And Emily, I thought, brought a very interesting perspective into that. So you can have urinary or fecal incontinence, stomach pain, dysphagia. And why is dysphagia? Well, because if you have very important dysphagia, you may be tending to avoid activities like going to a date to a restaurant, or even like, and that's another topic, but oculopharyngeal muscular dystrophy bring excessive saliva during night, and the patients were reporting that they have a loss of intimacy with their partner because they are not sleeping actually in the same bed anymore because of that process during the night that they have to clear out their excessive saliva. Next. There's also some cardiac issue that can bring fear of triggering heart problems. And of course, CPAP and ventilation will be affecting intimacy with the noise and partner not being able to sleep in the same room. Next. Gynecological system. Well, very few data. I know that there's a team at Stanford that is actually looking at women's health. But we know from discussing with general practitioner and patients that there's a lot of menstrual pain and related problem and recurrent urinary tract infection in some of the neuromuscular disease. Next. So the main thing is to keep in mind that several impairment can lead to different impact on many areas of sexuality. And as a physician, while observing those impairment, it would be important to ask the patient if there is any impact on their sexual life, and then start discussing about how they can overcome it and how they can find solutions. It's need to be grasped in an ecological way also, because if you have trouble with your hygiene, well, then it's difficult to think about, okay, I need to take my shower before having an intimate relationship with my partner. This will take me energy. This will take me planning. Then we go finally into that intimate relationship, which needs to be more planned than, in other situations. But then after that, I have to think that I have to do my own hygiene, or I have to ask my partner, and that again ask energy, and I need to transfer in the bed, and I need to ask him to help me with removing my clothes. So that's all the things that needs to be thought of just for something that should be in quote, spontaneous. Well, I mean, that spontaneity decreases also when you have children and adolescents, but, that's another one. And it needs also to be a very team approach with the people affected by neuromuscular disorder at the center, and providing them with an interdisciplinary healthcare team to address the problem. Next. So how should I open the subject of sexuality with my patients? Next. So the first thing that I tell all the people, I've been giving also this conference quite a few times to clinicians, and I wished I could have been with you today. But the first thing you have to look at is your own bias, your own discomfort, your own story, issues with sexuality. We all come from a different place. We all had different experience. We envision sexuality in a very different way, depending on how we were raised, our culture, our age, or, our different lived experience. And so this is where sometimes it's a very touchy subject, and we need to be conscious of our own bias before addressing, sexuality. And I mean, there is sometimes confronting stories that will bring back even some emotions to you. And so you need to be conscious of that. And you need to realize that if you're not at ease to talk about sexuality with your patients, you need to at least that someone in the team will address it with the patient and its family if it's a youngster. I think that that's very important because, as we said, there's a lot of patients that will be very shy to address it or don't even know that there's something that can be done, with that. Next. So who should address it first, the patient or the healthcare professional? Next. And so, and this is that was in 2013, that was the most recent that we found, but despite that 60% of healthcare professionals believe that sexual difficulties should be addressed, only 6% initiate the discussion on a frequent basis. But why? Next. So what they feel is that, and that's come from different study, people are uncomfortable, they have a lack of training. Even in training like occupational therapists or physical therapists, we have very few hours on sexuality and how to help patients, find proper answers. There's also absence of sexologists in the healthcare teams. And a lot of the clinicians reported that they feel that they're going to open a Pandora box. Next. And we prefer to say that it does not exist. Next. And that is not your role. Next. So research showed that patients do not voice their concern about sexuality and sexual health because they prefer healthcare professionals to raise the subject first. And Emily has brought it up very nicely, saying that she had, in quote, the ideal parents because they were already in a place where they knew about disability and they knew about, being able to voice your concern, but not all of the children and the adult will be trained to be their own advocate. Next. So what we use at our clinic is the explicit model, which is a model to really go through all the phases related to intervening in sexuality. So the first one is permission. So that means that you are informing the patients that it is okay to talk about sex, that it is allowed, that it is, that you could discuss with them. And then after that, there's three others. So limited information, which is giving just general information about, if you have SMA, here are the, general problem that you could experience, and here are some options. And then as you move on, then you can start to discuss with your patient about a specific situation and specific suggestions. And there's also a fourth level that could be done like in physical therapy, where it's called intensive therapy, and it's like perineal reeducations, or it could be also intensive therapy by sexologists, or there's different healthcare professional that can do that. Next. So how do you give permissions? You can have flyer or poster in the waiting room. You can have summary sheet of your own profession intervention target. And you can also have direct permission. And what we usually say is that we go from a general perspective, like several women living with SMA have concern regarding their intimacy or their sexuality. Is that something that you have experienced? Would you like to talk more about? Or is there sometimes it's specific to a situation? So difficulty have been noted that in undressing, which can have an impact on their sexual habit. So it's bringing a generic example to bring up about the discussion. You need to use the right word and to choose the right moment. Next. I will give you very rapidly a rough overview of how different healthcare professionals can enable sexuality for neuromuscular patients. Next. So it's a team effort, and each member is trained in sexuality. The patient can choose the team member with whom they feel most comfortable addressing their sexuality issue. So sometimes the patient will bring it to his nurse case practitioner or the occupational therapist or the physical therapist. It doesn't really matter. What matters is to take an holistic view of sexuality and then referring the patient to the right people for each type of intervention. Next. So physician can, and that's just example, that's not the full array of practice, but can address decreased libido, pregnancy, vaginal dryness, abnormal bleeding between periods, and infection. Next. Nurses can assist with the execution of many of the suggestions given by OT, PT, and MD. And there is sexual health clinicians that are nurse specialists in this area that are wonderful allied, but they're not often present in the clinic. Next. Social worker can play a large role in educating and counseling partner and family around sexual and fertility issue, and also something not often discussed, but trying to find funding options for the purchase of different equipment that I will show in a few minutes. Psychologists can help with self-esteem, assertiveness, and positive self-talk, and they can also address trauma around sexuality. Next. Physical therapists now can educate and assist clients with skills such as transferring from wheelchair to bed, repositioning in bed because it's an active thing, having a sexual relationship, maintaining balance, maximizing comfort. And there's a very special issue on perineal re-education, which is an advanced practice. But there could be a lot of pain during sexual encounter for different reasons. And physical therapists can have a very important role in decreasing that pain and can also improve the incontinence issue, which would be a factor preventing sexual relationship. Next. For occupational therapists, we will use to help the patient organize his daily routine to allow time and energy for sexual activity. Personal hygiene, will discuss it, compensating for reduction or loss of function, and also adapting sexual device. And I will bring you some example in a minute. Next. So what are the interventions we can do? Next. Muscle weakness. Of course, a lot of our neuromuscular disease now can benefit from regular exercise to improve or keep muscle weakness, muscle strength. We also will work on modifying sexual position, bringing also a very open discussion that sexual activity doesn't equate penetration. There's a lot of ways to have sexual activity, to have intimacy without necessarily going for penetration, which will need a lot of muscle strength and will bring fatigue. Practice position before trying into a sexual context. I have given numerous talk to patients, and what I tell them is that they have trouble, they have neck pain, back pain, they have difficulty assuming their position. I say, just practice. Put on clothing and just practice position with your partner, and just not doing it while you're in the action, because there's a lot of, feelings, emotion related to that. So you just need to practice and having fun trying to bring in pillows and things so that you find a position that is comfortable and that you can enjoy the moment. Next. Pain management is very important. We need to treat pain so that, and it can come from very different sources like neurogenic pain, dryness, myotonia. You will have a period of rest and relaxation before it, so to reduce pain, and modifying the position. There's a lot of pain that is brought up by the usual position that we used to have with our partner, but we need to change those positions and we need to adapt. And sometimes it's very difficult. I have men that were affected by neuromuscular disease coming to me and say, I used to assume a male position, and you open it to me that it could be something different. You need to try something else. But this is difficult because that brings a lot of emotion, and psychological issue that doesn't need to be addressed only by DOT for sure, but needs to be addressed as a global, issue. Next. Contracture and range of motion is also important. Next. Physical activity is super important because it will improve mental and physical well-being. And there is also a lot of study that physical inactivity can increase the risk of developing sexual dysfunction. Next. Energy conservation technique is very important so that we tend to use less demanding, more passive position, and exploring alternative of penetration such as oral sex, which can be less demanding. Next. There is diseases, neuromuscular disease that will bring erectile dysfunction, and that can be a negative impact, and we need to discuss with your physician or your physical therapist that can also bring some help with erectile dysfunction. Next. Female lubrication is also something that is very important and very common in neuromuscular disease, although never documented. And there's different lubricant that will bring different options for women, but we need to educate women about those different options that they can use. Next. Menstrual hygiene is rarely spoken about, but can be a large challenge for women. Now there's new wonderful product that can be, used, but you need to discuss it with your patients because putting tampons with limited, fine dexterity can be a challenge. Next. There's also the incontinence. We briefly discussed about it, but we need to discuss this as well because some people will stop having sexual activity because incontinence, but there is things that you can help to decrease those symptoms and to also prevent leaking on the bed, etc. Next. Respiratory and cardiac implications. There's several things that can be taught to patients, like not consuming alcohol 3 hours before sexual activity, plan sexual activity when well rested, and really assessing and discussing with your patient if there is real risk of cardiac implication or respiratory implication, because some patient will feel that their cardiac condition is not compatible with sexuality, which may not be the exact truth. Next. Positioning, of course, I will give you some of the example in a minute. I think they're next, just to show. Yeah. So there's a lot of amazing technical aids on the market. Yes, you will have to go to how do you call that in English? Well, whatever, where you get sex toys. Can't recall the name. Sorry for that. But they have a lot of amazing stuff. Their sellers knows because there's a lot of people with different disability that goes to their store. So I bring my occupational therapist student to the sex store, and we discuss with the counselor, and we see, and there's a lot of website, and at the end of the presentation, there's a lot of good website for sexual toys and sexual adaptation. Like the Rider Mate is amazing, and the Intimate Rider is amazing for men to help with the pelvic movement. There's the electrical bed when you can play with the position, so that helps also when you're limited. Next. There's different position that you can use, and you can just roll back, Tina. There's different one. I just want to say that you need to be creative. The other way. Yeah. You just continue on rolling. I just want to show very different positions that can be, again, and all of them have benefit for different activities. And that's really important that okay, just stop there. Yeah. So it's really important to bring the patient to realize that there is different options and that they can practice with their partner, that they can try it on. And often one of my OT that is giving the conference with me usually will even will work with the patient just to put pillows and different magic mount or things like this, so that they and of course they're all dressed up, but they just try the position, say, okay, so yeah, if I move like this is good. Okay, so there's that level that you can even go. There is a lot of sex object. There is a lot of things that can be used to help the patient either to hold the sexual objects or either to use one. And it's really important to talk about with your patients about their sexual need. And it's not because they don't have a partner that they don't have sexual needs. And also it's good for the women and the men to have a time to even experience their own sexuality, because if they have trouble with their end and they're not able to masturbate, well, then it's very difficult to know oneself. Next. You got also all sorts of toys for men. Next. Again, there's very, very different options. You can go, Tina. I'm sure everybody's awake right now. So I'm sure I do present on sexuality on every talk that I talk when I teach on occupational therapists. I become very creative, and I always get the attention of my students. So my conclusion is that sexuality and intimacy are part of a fundamental need. And I've started talking about, no, I made myself a promise when I was working as a camp counselor in a Duchenne muscular dystrophy summer camp with boys. And they had so much pain and despair and difficulty with not being able to have, their own sexuality. And I was an OT at the time. I was just a college student, but it made me realize that those boys were in need of having intimacy with themselves and sexuality and being touched and being loved and being caressed and being looked at. And I think that we need to be more open to the teenager, but even the adult and the old age population. I mean, I'm turning 50, so I'm turning on the other side, and I don't, I think that at all ages, you can have intimacy, and it needs to be allowed and discussed and facilitated. And so there's many ways to adapt to your sexual life, and we need to bring that forward. Next. And the next one, you can go next. Just a little bit about just 2 slides because I still have 2 minutes on go. Internet dating. Very important to discuss with your patient, to inform your patient. There's a lot of our teenagers that get into that internet dating. And although there's a wonderful website, there is also not so wonderful, dating site. So just to do that. And here I put some extra resources if you have any interest. We do have clinical care guidelines both in French and in English, and there's a lot of other resources. Next, and then you'll see the website and everything. There's podcasts on that if you want to know more. There's plenty. I mean, it's not that there's no resources out there. So I hope you enjoy that talk, and even you can use it yourself. I mean, it's very fun to go through those resources. That gives you idea also.
There's always concern about bringing up sexual issues with patients and not having solutions, that this will exacerbate the patient's sense of the problem and being without help. I mean, do you have any sense from patients whether or not they've experienced that? I mean, is it worse to bring it up and not have solutions, or better to at least acknowledge the problem?
I think, and Emily can probably speak better to me than that, but I think that addressing the problem is the first step. Then maybe recognizing that you're not the best to talk about it, but that you need to feel a little bit dedicated to find resources when you, but even opening it up will bring the patient at least to realize that it is something that is okay, that they have a right to have sexuality, that they have a right. And oftentimes, yes, we've got boys that would love to date, or to have a dating, having a girlfriend, and there's no good solution for that. But then you can start, and nobody, and I mean, it's a gradual process about talking about masturbation, just, how do you say that? But, making it normal that people masturbate, and maybe he needs a special object or he needs a special situation, but that's okay as well, So, and if you don't feel comfortable, is to maybe try to figure out a member of the team or some community resources that are out there that can help with that specific issue. And
Great.
that's that.
One other issue that I think is important in this, and that's with regard to the social isolation that a lot of our patients have, in addition to, having unmet sexual needs. And do you think those two really have to be addressed together? I mean, or, can you address them independently? I mean, how do you deal with that? I mean, I think a lot of our Duchenne patients especially are profoundly isolated, and it's something we need to tie in here somehow. I'm curious what your thoughts are.
Yeah. Well, I think that's, again, what is fantastic with the interdisciplinary team is that, let's say the social worker will put more effort into, the social environment, trying to find out community resources or special things. And then as an occupational therapist, I can help with making sure that the building is accessible, or that they don't have, that the barriers are, removed as much as possible. And then maybe, so it's really about a team effort. I think that it's there, but it's certainly linked that there is a lot of social isolations, and that needs to be as well addressed in that sense. So I think that there's no clear answer, but I think that it doesn't need to be addressed together, but it needs both to be addressed, by different members of the team.